So I was asked to speak here today, and from my perspective, being able to do something like this is an amazing opportunity for me to see all of the patients that I haven't maybe cared for that get to go through, that have gone through transplant and come through the other side, but maybe continuing to deal with a different disease, trading that malignancy for graft-versus-host disease, which can always be a very difficult thing. When we talk about these things prior to transplant, everyone, we focus on the cancer that we're treating. Because the vast majority of people who get donor transplants are getting it certainly as adults, and I'm an adult doctor, are getting it because of the fact that they have a cancer that is high risk for, unfortunately, causing them to die. And so we talk about what options we're going to have as we go through things, but we frequently will end up trading one disease for another. And I know, even when I talk to patients and talk about the things that can happen, human nature says, it doesn't happen to everybody, so it's not going to happen to me. And unfortunately, that's not the case. And so symposia like this are amazing for all of you to interact with other people who've gone through some of the same life experiences and been able to come out the other side and to survive, and more importantly, to thrive. And I know there were a couple talks yesterday about thriving that were very, I thought they were very useful, because it's things that we don't necessarily focus on as transplant physicians very well. We're always dealing in that acute issue. So being able to speak here today is quite the honor. So I was asked to talk about chronic graft-versus-host disease of the skin and connective tissue. And the reason that connective tissue is included into that is because it really is part of that skin area. And the skin is our largest organ of the body. It encompasses your hair and your nails as well as that subcutaneous, or just under what we see skin, that can get thickened. And I'm going to talk a little bit in an overview about disease manifestations, and then talk about some risk factors for the development of chronic graft-versus-host disease in general, as well as some specific things that can impact development of skin chronic GVHD. I'm going to do a very brief overview of treatment options. The reality is that the vast majority of you who are in here probably are very familiar with the treatment options that we have to use for graft-versus-host disease. And steroids, prednisone, first and foremost, are the most common. We're also going to talk a little bit about skin cancer prevention. I know I have a couple of my patients that are sitting in this room, and they've heard me talk about sunscreen, sunscreen, sunscreen all the time. And I'm not going out in the sun, but it doesn't matter, because if you walk outside, even walking out to your car, you are getting some exposure to the sun. And the sun can be, as beautiful as it is. So as beautiful as it is, we can still have significant issues from that minor sun exposure. The other thing that we're going to talk about is I want to actually talk about the role of the patient and how to kind of take charge a little bit of what things need to be reported to the physicians, because as we know, we don't always get enough time with the doctor, or the doctor doesn't have enough time to spend with you. And both of those are important things to make sure that you've got those questions kind of highlighted about what you're concerned about. And for the caregiver as well, and particularly when we're talking about skin GVH, because you're going to have things that are going to be in areas you can't see. So what is chronic GVHD of the skin? It is the most common type of chronic GVHD. The reality is that more than 50% of patients who have chronic GVHD will have some skin manifestations. Now, it could be minor manifestations, minor in the sense that it doesn't require us to use systemic therapy. It can be some nail damage. But for some people, it can be hair loss, or it can be changes in the skin that result in stiffening of the skin. And I've got lots of pictures in here, which is always, good and bad, but important to see. But this graft-versus-host disease occurs when the donor's immune system cells are attacking your healthy body or your skin. The flip side of that is that graft versus cancer effect. And so we have, two sides of a coin, but when we're getting continued ongoing graft-versus-host disease, then we're getting ongoing damage. And in chronic GVHD of the skin and chronic GVHD in general with any of the organs involved, it's really causing scarring and inflammation. So the previous speaker was talking about scarring that occurs in the tear ducts, and so that you're not able to necessarily make those oils and things that need to keep the eyes lubricated. Same thing with the skin. You can have superficial scarring, you can have deep scarring, you can have scarring that prevents the hair from growing because you're getting scarring in the hair follicles. So the reason I showed this picture is because normal skin actually has multiple layers. And so when you look at this up here, even your nail has multiple different layers. And so we've got things like the hair follicle that can be scarred. You can have scarring of your sweat glands. And if you get scarring of your sweat glands, you're not going to be able to regulate your body temperature very well, because we sweat to get rid of excess heat. The fat down in here can scar, or the connective tissue can scar, and those things can result in making it difficult to fully extend arms. So it's not it may not necessarily be the joint that's being affected, although we know that graft-versus-host disease can affect your joints. It may actually be just the skin and the connective tissue that is no longer pliable and it can't stretch. So when we talk about skin manifestations, there has been a consensus group that has continued over the past now more than a decade looking at how we characterize chronic graft-versus-host disease. In the olden days, transplant started in 1968, so in the 70s and 80s and even in the 90s, when we talked about chronic graft-versus-host disease, we called it limited or extensive, which really didn't do a whole lot of description. But this consensus group has come up with new ways to kind of diagnose and talk about chronic graft-versus-host disease so that we can kind of say, yes, this definitely is or not. And when you look at this, this is looking at just the skin. And I know it's not easily legible up here, and I really put it up here just to show that there's so many different manifestations that are involved in skin and connective tissue chronic GVHD, that we need to be able to kind of ask about all of those. And some of these are common and seen both in acute and chronic graft-versus-host disease. So we talk about rash all the time, but the rash can be very different depending on whether or not it's an acute graft-versus-host disease or a chronic graft-versus-host disease, and sometimes it can overlap and have similar manifestations. So when I think about patients coming in and I'm talking to them about, how are you doing? And I usually ask some about what symptoms they may be having to try and figure out if there's anything subtle going on that I need to be concerned about. And so symptoms from skin GVHD can be quite varied, and they're not necessarily diagnostic of chronic skin GVHD, but there's something that I need to be thinking about in moving forward. So itching is very common. The reality, though, is that most of us who get dry skin are going to have some itching, and so it could simply be we are not using enough moisturizers. I find that more in my male patients who seem to have an aversion to moisturizer, but that's okay. A burning sensation. So even if you get exposed to a little bit of sun or heat, you may have a hyper reaction where you're feeling that burning sensation. The pulling and tightening sensation goes back to that connective tissue that we talked about. So that subcutaneous area of connective tissue and fat, if it's scarring, your skin underneath is going to be thicker. And so it may not have that elasticity to be able to move or stretch like we would normally. Easy skin tearing can happen. However, that's also managed by the fact that most of our patients with graft-versus-host disease are on steroids. And steroids also cause easy skin tearing. And so is it a symptom of the disease? Is it a symptom of the treatment? I'm not sure that's terribly relevant in the patient who's experiencing it. And so just trying to figure out what those symptoms are and what we can do to try and help with those is important. Additional symptoms are things like sores that will heal slowly. So again, that can be a symptom of the skin and damage to the skin because you're not able to heal. You've got too much scar tissue to be able to have that sore heal quickly. It can be from the therapy that you're on because when you're on immune suppressive medications, your ability to heal is delayed. Joint stiffness, I talked a little bit about that. You know, if that connective tissue is tightened across here, you may not be able to extend your arm fully out. Interestingly, difficulty taking a deep breath and getting full quickly can actually be manifestations of skin GVH, not necessarily from lung GVH or from the spleen being enlarged, because we have muscles and tissue that have to expand in order to be able to take a deep breath. And if that tissue is scarred across your chest or across your abdomen, then you're not going to be able to expand as well. And if you can't expand, you can't take a deep breath, and you can't eat as much. You can't create that food baby that I tend to do on a frequent basis. But it's because things don't stretch. So I have a bunch of pictures, like I said, and we're going to talk about some of them. I'm not sure how well they're all going to kind of play up here. I don't know. Is it possible to dim the front lights? Technical difficulties. So this top picture here shows how you're getting some hair thinning. And so there are some people who will, bald is beautiful, it's okay, but when you're having things like this, it's because of scarring of the hair follicles. And so it's something that can be a manifestation of graft-versus-host disease that a lot of times people as patients or their caregivers don't think about. It's like, oh, it's just something that's happening. But this is actually a manifestation of things attacking your healthy hair follicles. Difficulty opening the mouth fully. If you have tightening of the skin, and I think someone in the last session had mentioned about the tendons pulling down in her face, it's the same thing. If those tendons are getting tightened, or if the skin itself is scarred and tightened, then you may not be able to fully open your mouth, which for some of us that's probably okay, but for some people it can make things very difficult in terms of eating or talking or drinking, those kinds of things. Dimpled skin, and I've got some other pictures in here, but that dimpled skin is where you're getting that scarring in that early subcutaneous tissue or subcutaneous fat. And so that's another manifestation that can happen in chronic graft-versus-host disease of your skin and connective tissues. So if you look at this picture up here, and being, that this is kind of a talk for survivors, most of the pictures that we can easily find are the ones that are the really drastic changes. The good news is that only about 10 to 20% of people who get chronic graft-versus-host disease are going to have a lot of these severe changes. But for those who have them, it can absolutely devastate quality of life. And so these are things that if we can hopefully try and catch them earlier, we may be able to help stave off the more severe symptoms. So this is looking at somebody who has a contracture of the elbow and the wrist. They're not able to open that arm out because of the fact of the scarring that has occurred. You can have changes in the skin and the nails. So this doesn't show up quite as well as I had hoped, but you can see that the nail is pitted and ridged. And for some people, they actually lose the nail completely. You're not able to actually have growth of that nail bed. But you also see what we call vitiligo. So you have changes in the pigmentation where areas may be darkly pigmented or areas may be have lost their pigment completely. And then this is showing a lot of changes sort of at a waistband area. And you can get changes in the color of the skin, but you can also get that sclerosis change underneath the skin, and that may make you feel a little bit tighter. It can affect how you're able to balance in your core musculature, but it can also affect that ability to eat and regulate your bowels and things like that, because it's all connected into how our body is able to move. So this is looking at some additional things, looking at subcutaneous changes that are sclerosis. So sclerosis means that it's really a scarring, and it can be that thick scarring. And what you can see in this picture here is there's actually dimpling of the skin along the area of the tendon here. And with that dimpling of the skin, that's occurring because of the scarring underneath the surface of the skin. Whereas this particular patient has a lot more manifestations that are superficial. They're not a deep skin involvement, but more of a true topical skin involvement. But you'd be worried, given that this person is having some evidence of hair loss, that perhaps there are changes that can go along with that as well. Again, we mentioned vitiligo. This is a better picture of the nail changes that can occur. Oops, sorry about that. So risk factors for chronic GVHD really are associated with many things, and I kind of picked a few that can be involved in the manifestations. Includes older age, both of the recipient or the donor. So as we continue as transplanters to transplant older and older individuals, and old keeps changing as I keep aging, but that older age, we do know that we get some more chronic graft-versus-host disease. And if we're transplanting an older patient, we're also going to be using most likely an older sibling if we have that opportunity. Using peripheral blood stem cells. We know that peripheral blood stem cells do increase the risk of chronic graft-versus-host disease. There are studies that have demonstrated this both in the setting of related donors as well as unrelated donors. But the change is minimal, and there are benefits to using peripheral blood stem cells. So a lot of times, with the exception of certain diseases where we don't need a graft versus tumor effect, we often will still use peripheral blood stem cells. If there's any degree of mismatch between the donor and recipient, that obviously can increase the risk of graft-versus-host disease. Although that changes a little bit in the umbilical cord blood setting, where we typically have less graft-versus-host disease despite mismatches. A female donor to a male recipient, and that's in part because women have two X chromosomes, men have an X and a Y. The Y chromosome is an area of difference, even though the HLA typing may be the same. And prior acute graft-versus-host disease is something that can also increase your risk of chronic GVH. Other things that can be potential triggers specifically for skin GVHD are areas that have prior skin damage. So this particular picture is from a patient who developed a circular area of chronic GVHD from the site of where their previous tunneled catheter had been. And there was ongoing inflammation, and so even though the line was no longer there, the patient developed those changes. And this, you can see it's nice in a pattern of where you would have been exposed to the sun. This person was wearing a tank top that showed, and it had a deep V, and that sun caused and triggered graft-versus-host disease. So when we talk about treatment options for chronic GVHD of the skin and the soft tissue, when I look at a patient, I look at what's going on specifically with that patient. I look at whether or not there's the presence of that deep sclerotic changes, whether or not it's affecting the vast majority of the skin versus a smaller area, just like that one patch that we saw in the previous picture. In the Sclerotic GVHD, as we talked about, is affecting the deeper tissues, which means even though I could use topical therapies to try and treat the skin, it may not penetrate where we need it to penetrate. And then extent as well. And then I also look at the extent of GVHD in the other organs. Because if I have a patient who has liver GVH and maybe some GI GVH as well as their skin GVH, treating the skin alone is not going to be particularly useful to that patient. And so I have to take all of those things into account. So there are topical treatments, and most people who have superficial skin type symptoms will get topical treatments, and that usually will be the first thing that we try. But systemic treatments are also available, and prednisone is always our mainstay. It's what we go to first. But there are other things that we can do, like phototherapy and supportive measures, and I'm going to talk about each of these a little bit. So the topical therapies are really related to steroid creams. There are different strengths of those creams, and they can be mixed with different compounds. I personally am partial to using, for my patients, a triamcinolone mixed in a eucerin cream because it is better absorbed, so I do get a little bit of that deeper penetration. In patients who have a very small area of skin that's involved, Protopic is a topical tacrolimus ointment. And so that can be used to try and treat some of those smaller areas. And then even though this isn't talking about GI, GVH, where you've got those oral manifestations, you can use mouth rinses such as a dexamethasone mouth rinse, or there's a triamcinolone steroid paste that can be used as well. As I mentioned, prednisone tends to be our mainstay of therapy, and despite multiple studies that are continuing to be done, we haven't found anything better. Looking at combination therapies, something plus steroids, all of those things we do try and do, but steroids are considered the frontline therapy when we need to use systemic treatment. Prevention of graft-versus-host disease, we're using the calcineurin inhibitors, mostly tacrolimus, to help prevent it, but it's also a treatment. So oftentimes we are adding steroids to that tacrolimus, and because of the toxicities for prolonged steroid use, I will try and continue the tacrolimus where it is, but continue to decrease the steroids as I can. But if I'm not able to taper my steroids, then I have to go to next line therapy. And there are a multitude of options that we have, and that's good and bad. When we have a multitude of options, it means none of them is the ideal therapy. But it also means that I can look at the pros and cons of each of those therapies in terms of the patient and what's going on with them to decide what I want to try and use. There are also ongoing studies looking at newer drugs that are available that may be FDA approved for other indications, but are available that we know have some benefit in graft-versus-host disease. So some of those targeted therapies include rituximab. So rituximab, for anybody who's had a B-cell lymphoma, this is actually a chemotherapy drug that almost every B-cell lymphoma patient will receive in their lifetime. But B cells are a specific type of immune cell that can also be contributory to chronic graft-versus-host disease, so that may be an option that I can try. Imatinib. Imatinib is a drug called a tyrosine kinase inhibitor. It has been used and shown some benefit in sclerotic chronic graft-versus-host disease, and so it's something that we may use, but it's a drug that was developed to treat chronic myeloid leukemia. And so trying to use what drugs we have available and knowing how they're targeting things helps us to tailor to the patient what's going to be the optimal therapy choices. Sirolimus is another drug that we can use. It has its own potential risks of side effects, but it is another drug that we use, and it works actually quite well in patients with sclerotic graft-versus-host disease, but I wouldn't use it unless there's a lot of other systemic manifestations as well, because it has some toxicities that we worry about. So phototherapies, we have topical phototherapies like PUVA, which is sorolinib, which is a drug that will target and damage T cells. And it's using ultraviolet light. And I know I just preached about sunscreen and not doing this, and so it's somewhat counterintuitive, but it does have some help and some benefit. But you only want to use PUVA if there's just skin involvement. And if we have somebody who's got skin and mouth and eye, that's not going to be my choice. So that person is going to do better getting extracorporeal photopheresis, or ECP. And ECP does a very similar process as the PUVA, but it actually has the cells are being extracted from the body, they're treated with this methoxysorolin, and then the UVA light. So you're not getting the UVA on the skin, it's really just targeting those cells, and then sending those cells back into the body. But it's trying to kill the cells that are causing the graft-versus-host disease in the skin. But because it is systemic, it's a systemic therapy, since our blood circulates everywhere, it may provide some benefit in other areas of chronic GVHD as well. However, ECP can be very time-consuming. When we start ECP, first of all, you have to have a special catheter placed, what we call a photopheresis port. And then you have to plan that you're going to be at your transplant center that's doing this 2 days in a row every week for about 4 weeks. And then it goes to every other week for a couple months. And then it goes to monthly for a few more months. But it's 6 months of therapy at least. And so that's something that is an impact on your quality of life. But if we have something that can help to do this, it does help skin, but it also helps some of those other GVHD changes, and doesn't have necessarily some of the same toxicities that a drug therapy may have. Supportive measures. These are really, really important, and they seem a little silly, but if you think about what this is in terms of scar tissue, doing gentle stretching to try and make sure that those joints and that subcutaneous tissue is remaining pliable is important. And gentle massage can help with that as well. We're not talking deep tissue massage or any of those things, but gentle massage while moving the joint areas and tendons can help with that. And then for some people who do develop those unfortunate contractures, you can also have occupational therapy that helps with increasing range of motion, also doing some strengthening and splinting to try and keep those joints where they're going to be more open. So I do briefly want to talk about skin cancer risks after transplant. For auto transplant, it's not nearly as high as it is for allogeneic transplant, but it's still an increased risk. And this is a study that came out of Sweden where they register all of their patients nationally to be able to kind of look at these things. And so for an auto transplant, cancer is about 1.5 to 3 times what you would see in a normal person, but interestingly, the basal cell and melanomas really aren't higher than the general population, just the squamous cells. However, when you move to an allotransplant recipient, it's substantially worse. And so squamous cell cancers occur 18 times higher in a person who's going to have an allotransplant than in the general population. Melanomas are 5.5 times higher. There's reasons that we also talk about sunscreen to try and minimize that skin damage. Now, it is slightly higher if somebody received total body irradiation as part of their conditioning. So I want to close with really what you should do as a patient to help facilitate your own care and your health, primarily as it relates to skin GVHD. This whole symposium is talking about these things, but specifically related to skin GVHD. Report these symptoms. Ask, my skin looks abnormal in color, or the skin on my arm here feels funny. It's thick. I don't understand why. Or I'm having itching all the time. And there's a symptom scale that we can use, looking at, not at all to extremely. And that's something that has been tested in patients with GVHD. The other thing to do is to moisturize regularly. Make sure you're using a thicker cream that's going to be a little bit more penetrant. And actually, ointments work really well if you do have that skin thickening, because it will penetrate better. You want to avoid outdoor activities during peak sun hours. So 10 a.m. to 4 p.m. is really a bad time, and the further south you are, the longer that period goes. Use sunblock, okay? SPF 30 or higher, just to minimize anything. And I tell my patients to get in the habit of put it on every morning before you get dressed, and then reapply if you're going to go outside, so that you're in the habit and it's always going to be there. And then also examine your skin for new spots. And you want to see a dermatologist on a yearly basis, really to try and get a full skin exam. Your transplant physician is going to be looking at your skin, but not necessarily doing the great job of looking for some of those really abnormal spots that can become skin cancers, because we're also looking at the rest of you at the same time. And that's what the dermatologist is going to do, is focus solely on your skin. So just to summarize, chronic GVHD of the skin is very common. It has a very wide variety of symptoms. We do have multiple therapy options to assist with it, but oftentimes we still are trading that one disease for another when we talk about chronic GVH. And then early recognition of signs using moisturizers, avoiding the sun, can also help us prevent severe disease. And with that, I'll be happy to take any questions.
Thank you very much, Dr. Riches. We'll open the floor now for Q&A. There will be one mic here in the front, one mic in the back, so we'll alternate, and we'll start with you.
Great talk.
Thank you.
Are tendons included in skin?
Well, to some degree, we know that there is a separate area when we're grading chronic GVHD that's looking at the musculoskeletal system. And the tendons really are more a component of that. But if you have skin or subcutaneous thickening around that tendon, it's going to have some of those same effects.
Yeah, what I was experiencing is at night or sometimes during the day with my hands and my feet, all of a sudden it'll like tighten where it'll pull. And is that...
So there's a lot of things that can be contributing to that. You know, all of my transplant patients are on a very long list of medications, and many of those medications can also contribute to changes in electrolyte balances. And electrolyte changes can also result in contractures that you're describing. So there's going to be a multitude of potential reasons why it's occurring. And so trying to tease those out is not easy as a general rule, because you don't want to run and go get your labs checked at, 2 in the morning, and we're okay with that. But it's something that making sure that, if it's happening more and more frequently, we are going to need to keep a closer eye on electrolytes, in addition to maybe some physical therapy or occupational therapy to try and help make sure that we are keeping those joints and tendons stretched, and making sure that we're not having some skin tightening or subcutaneous tightening around those areas as well. Usually when it's something that happens like that and then gets better, it's not from the sclerotic changes of chronic GVH in the skin. It's going to be more likely potentially something that is related to electrolytes and or musculoskeletal GVH itself.
Thank you.
Hi. Just a quick question regarding sunscreen or sunblock. I'm curious, is there a big difference between the paint kind of zinc-based ones, the sunblocks, versus the spray-on sunscreens? And do you have any specific, perhaps, recommendations for ones that work well or that patients have liked?
So patient preference in terms of what a patient likes is going to vary dependent upon personal preferences there. From my perspective, I think you get better coverage when people are doing the sprays. That being said, the sprays aren't going to penetrate nearly as much. And so if you're using a thicker cream-based, it is going to penetrate more to likely maintain better coverage for a longer period of time. So at least if you're starting to put on your, if you do get in the habit of putting sunscreen on every morning, I'd actually start with the cream-based, and then maybe when you're reapplying, be able to use the spray-on, because that is a little bit easier to do, and you can often get those areas covered without needing much assistance.
I have a bunch of questions, but I won't ask. Two questions. The simplest one is, what do you consider a low dose of steroids? And, like a maintenance dose, what is low? And the other one is probably a crazy question, is how do you actually determine that it's GVHD and not drug reaction or some other phenomenon that is attributed to a lot of, if somebody walks in with a rash, you can say, well, you were rolling in poison ivy. But you know what I'm saying is, how do you actually determine that it's GVHD?
I'm going to tackle the first question because it's much easier. So any time that I'm giving patients steroids, if I have you down to 5 milligrams a day, that's what your body should be making normally from your adrenal glands. So that's sort of what we call a baseline replacement dose. Anything above that is supraphysiologic. And usually I consider very low dose steroids to be somewhere between 5 and 10. Keeping somebody on a maintenance dose between 5 and 10 still has a lot of potential long-term toxicities, including hyperglycemia or elevated blood sugars. For people who are diabetic, that can certainly worsen their diabetes. Bone loss, osteoporosis, muscle loss with those myopathies. And so I always try to get my patients completely off of steroids if I can. And it can often be a challenge because you can decrease people down and they do okay, and then we have to start over again. And so for my acute GVHD patients, if I'm going to start steroid therapy, I usually start at 1 milligram per kilogram, which is a very high dose, and taper down. For patients who are new chronic graft-versus-host disease, I tend to start the steroids at 0.5 milligram per kilogram and rarely go above that 1 milligram per kilogram. In terms of your other question, so we use biopsies frequently. Unfortunately, the pathology is going to show inflammation, which you could see in that poison ivy rash. It can show different changes that may be more like a drug rash. And I would say 9 times out of 10, the pathology report is going to say could be consistent with graft-versus-host disease. And so a lot of what we do is based on clinical signs and symptoms. And the biopsy we use for confirmation. It's more important in certain things like a liver biopsy or even a GI tract biopsy. But there are very few things that cause that sclerotic change that isn't an immune reaction. So it's more that red rash that becomes very difficult to say, is this GVH? Is this related to a drug? And looking at a rash over time does help to help delineate some of those changes. But unfortunately, we're still looking for that magic test that we can do to say, oh, this is graft-versus-host disease, because even pathology isn't perfect.
With alopecia related to GVHD, is there a role for topical treatments, or is it systemic only?
So you could certainly, it would depend on the patient and other manifestations of GVH going on. You could certainly try and use some topical steroids if the alopecia is the main symptom of your GVH and you're not having eye or mouth or gut symptoms, then you could certainly try and focus on using just the topical therapies. I think it's reasonable in the setting of patients with multiple manifestations of GVH to combine, to use not just that systemic therapy, but also use some topical therapy to try and help treat the area that's truly affected. It'll help hopefully also get you off of some of those steroid agents, systemic steroids, a little bit more quickly.
And what would be a good topical
So
treatment?
in areas that are sensitive, so areas like the head, the face, and the groin area, we want to use those lower potency steroids. So usually just starting with a hydrocortisone and trying that. And if we're not getting any benefit from that, we may be able to use something more like the Protopic in certain areas that would be having difficulty getting that hair to grow.
Thank you.
Excuse me, my question pertains to the scarring. First of all, that sounds like it could be pretty permanent. Is that reversible? And then, in your experience, can the scarring cause significant enlargement of an area like the forearm where it's significantly larger? And then finally, you had mentioned a triamcinolone eucerin ointment or cream. Well, that have to be by prescription. Is there a name for that?
Actually, it's going to be, it's compounded. So your physician should be able to write for it. It doesn't have a specific name. It's just triamcinolone 1% in a eucerin base.
Okay.
So the pharmacies will make it. So it may not be something that you can get at every pharmacy, but your physician should be able to write for that.
Okay.
That's the easy question. Scarring very definitely can be permanent. And that's why when I talk to patients and I encourage patients to tell me what's going on, it's because I'm trying to avoid getting to that scarring area if we can. And we may not be able to. We know that the treatment that we use for graft-versus-host disease is by no means perfect. That's why we have so many second-line therapies. And the scarring over time, just like any scar you would get from a surgery or an injury, can lessen over time, but it's not likely to dramatically go away. And yes, the scarring or enlargement of the area of a joint or of the skin around a joint could certainly cause a focal abnormality, similar to what I showed in the picture where you had the patient whose arm was kind of stuck like this. This person didn't have any, they didn't have a whole lot of subcutaneous fat, but everything that they had there was scarred. And so it is something that can unfortunately be permanent in terms of the damage, but what we can do is things like physical therapy or using occupational therapy splints to try and help increase the mobility. So oftentimes I'll talk to my patients about, sort of walking up the wall with your hands to try and stretch those joints and stretch the skin. Being able to push your hands down like this to stretch this area of the skin, or back like this to stretch this area, are important things that need to be done, and they're things that you can do on your own at home too.
Okay, I appreciate that. How do you decide if it's scarring and that systemic treatment's no longer going to be effective, that it's as good as it's going to get?
Unfortunately, that falls into the tincture of time. That is something that, a lot of times we'll keep patients on systemic therapy because we want to try and prevent other areas from getting worse. And so if I have somebody who I'm not seeing signs of improvement, but I'm also not seeing signs of worsening, and I'm concerned that this is likely to be some permanent changes, I will do a very, very slow taper and make sure and see people relatively frequently, maybe once a month, so that I'm not seeing signs of worsening in other areas, to try and get somebody off of that systemic immune suppression and the toxicities that go along with it. But there's not a test that we have that says this is permanent, this is not permanent. it really is a long-term course.
You've been so helpful. Thank you for all the good information.
You're welcome.
I have two questions. The first, I get cramps in my feet frequently. Is that GVHD?
And that's very similar to the question that you asked up here, in that some of those cramps could be certainly from GVH. It can be from electrolyte abnormalities. It can be from dehydration. So there's a variety of things that can contribute to those symptoms that you're having. I would make sure that when you're getting those kinds of cramping, trying to do a little bit of massage in that area and see if that helps to loosen some of those symptoms.
And I drink water constantly. I'm always way over the 64 ounce. But then I wonder, well, maybe that causes an electrolyte. Is there something else I should drink?
So there's no doubt that if all you're drinking is water, that can contribute to electrolyte abnormalities. I tend to tell my patients to do a mixture of water and the sports drinks. So Gatorade, and there's now, I think, like 40,000 flavors of Gatorade, so surely you can find one that's okay. But the Gatorade, Powerade, those kinds of things, because it does have some electrolyte repletion in there. And so that can help sometimes.
I will start today. Thank you. The only other, and this is minor compared to what everybody else has, but the tearing of the skin, almost if I look at my skin wrong, certainly if I brushed up against this, it'll start to bleed. Is that GVHD starting?
So it can be related to GVH. It can be related to medications. So if you're on steroids at this point, and since I don't know that can cause your skin to be a lot thinner as well. But even the chemotherapy, the conditioning regimen that you've had, has caused some changes to the skin. Dry skin will also tear more easily, so that's where those moisturizers come into play as well. You want to keep that skin well hydrated so it doesn't tear as easily.
I think in a more general sense, for me, I feel like I have some of everything that's being talked about, except probably the very serious cases. So with skin and with cramps and some connective tissue issues, and besides the sports drinks, are there some good vitamins or alternative therapies, acupuncture? I do yoga, and I think that is a huge, huge benefit. But just overall, it seems like I feel like I should be able to beef up my skin a little, do something. I'm really not on many medications, so I don't think it's medication.
So the one thing that we know is that, unfortunately, cancer chemotherapy and transplant ages you beyond what would be a normal aging process, which doesn't help any of these things, because as we age, we do get joint symptoms. We do get some of those things. And it's hard to, necessarily tell whether some of this is normal wear and tear as we're aging versus something far more serious in a GVHD setting. And so a lot of times when I sit and talk with my patients, it's trying to figure out how much is this impacting quality of life. Because if it's impacting quality of life, then it may be that we need to do something more intensive in terms of therapy versus doing, encouraging gentle yoga, moisturizers, and those kinds of things. Because it's those risks, benefits that we try and balance. In terms of supplemental therapy, acupuncture, things like that, I generally would not recommend acupuncture just from the standpoint of any time that we're going to be doing things to the skin like that, you're going to cause some inflammation, which is then going to cause flares of graft-versus-host disease. That's why even when we have people that are getting procedures, we saw in the picture the person who had their central line, that's where it caused the most graft-versus-host disease because there was a lot of inflammatory response there. I would stick with more of the gentle massage and things. As far as supplements, there's not anything specific. Fish oil can certainly be tried to help maintain, and it also can be beneficial at lowering triglycerides, which can sometimes be a problem in a post-transplant setting. I often caution against, a lot of other supplements simply because they're not generally regulated. And so when they're not regulated, we don't know what's in there. We know what they say might be in there, but we don't know what's in there. And we don't know how it may interact with other things. And so I always worry about some of those and have that conversation with my patients. And it's, this is why I worry. There isn't something that I can, I'm not going to tell you you can't take something. Just let me know what you're taking. So if I'm seeing weird reactions or weird interactions, I can gauge what's going on with that.
Thank you. I have GVHD of the skin, mild to moderate, but I'll often kind of break out in like these tiny red dots, almost, like little burst blood vessels, and they'll come on really quick, but then they'll also kind of fade rather quickly too. Like, is that a typical thing?
It is. We can certainly, and I suspect that most of those dots may come in areas that you had gotten either really warm or had been exposed to the sun or something like that. And so even a minor exposure to the sun can cause a flare like that. But that is a normal thing that we can see in people with chronic GVH.
Yeah, I'm sorry, I'm too close on it. Yeah, I had a couple questions. One was, I noticed on some of your slides a dimpled skin, and it kind of looked like cellulite, and I'm thinking to myself, is it cellulite or is it GVHD? I'm like, and I'm realizing that I'm thinking it's cellulite, because all of us get it when we age, but then I'm thinking, but it's painful, so maybe that's not cellulite. I don't know. But anyway, that's one of my questions. And the other one is on the muscles and the cramps, which I did get. My hand would all of a sudden go like a claw, and I got put back on another immune suppressant, Cellcept. And I was on that for a long time until it started tearing up my stomach, and I had to get off that anyway. But that's one of my questions is, how do you make the transition of thinking that it's all transplant, post-transplant effects of all this aches and pains and your muscles cramping, all that other stuff, versus you're just getting old, or you have bad, I have herniated discs. Is that really what's causing it, or is it? That's what I'm trying to figure out. And I know it's a toughie. I'm sorry, but
no, that's okay, because those are the real questions, and those are the questions that patients have, and frankly, they're the questions that we as the physicians have as well. That's why we continue to do clinical trials looking at biomarkers. We're trying to find a blood test that we can use to say, oh, no, this is graft-versus-host disease, and I need to give you steroids or Cellcept or tacrolimus or something, versus it's not GVH. It's unfortunately sort of what happens, normal aging process that we've accelerated. And there isn't that test available. So when when I talk to my patients, and I'm trying to figure out what's going on with them, I frequently will ask the questions that I would ask about graft-versus-host disease symptoms even before I take them to transplant. I want to get an idea of sort of those baseline symptoms so that I've got them recorded somewhere, okay, as much as I possibly can. I mean, the fact is that things do change over time. But doing things like that, specifically dry eyes. If somebody comes into transplant with dry eyes, right, it's like, okay, is that the same as it was prior to transplant? In terms of the cellulite versus GVH, a biopsy could be done to say, are we seeing scarring in there? But it's probably not going to change what I do, because if you have that dimpled skin, but it's not impacting your life. It's not keeping you from doing the things that you want to be doing, and it's not getting worse, I may say, I'm not going to put you on steroids because that's going to have a greater risk to you than having some symptoms of cellulite. And it's really a balance of trying to figure out what is that new normal, has been talked about, versus something that's progressing that I need to actually intervene. And without a specific diagnostic test, it is based on conversations with my patients and getting to know what those symptoms are and how to help my patients kind of cope with some of those symptoms. Mm-hmm.
Hello.
Hi.
Vitiligo is one of these symptoms of GVHD. And how is it not compared to or contrasted with sun damage? Is there a difference in what does one do about it? I think I have it, but it doesn't cause me any problems.
So vitiligo is from scarring in the areas of pigment, okay? So you're losing the pigment in those areas. And you can have sun damage where it's actually making areas darker, okay? But it gets into one of those symptoms, some of those symptoms of, we can put some steroid cream on it, see if it improves. But vitiligo tends not to improve dramatically even with topical therapies, even with systemic therapies. And so a lot of times we won't do any aggressive therapy or intensive therapy for that. I think in my experience with my patients, all the manifestations of skin, GVH, skin, nails, hair, tend to be the most burdensome mentally because they are outwardly seen. People know what's going on. And so that trying to help improve, vitiligo type symptoms is difficult to do, but perhaps sometimes vitamin E creams can maybe help a little bit, but it's not likely to reverse that pigment change.